Okay, now we're starting at the beginning. Isn't this better?
Yeah.
All right. So it's nice to be here. And I am going to talk a little bit about some of the recent activities of the board. I have some disclosures. My research has been funded by a number of federal and private sources. I belong to a lot of organizations, but I am not speaking for any of them today. My remarks are my own. I am a member of the New York City Board of Health, and as such, I've had the pleasure of watching the board's work over actually more than a decade now. So I'm going to describe briefly the role of the New York City Board of Health, talk about a few past examples of public health policies that have been implemented by the board. I'm going to talk to you a little bit about public health policy in the era of COVID. And then the board's most recent action, the declaration of racism as a public health crisis, will end with a brief discussion of that. So the New York City Board of Health was established in 1805. At that point, yellow fever was ravaging New York City. And the mayor decided that it would be good to put together a board of health to try to improve the health of the city. Unfortunately, the first iteration of the Board of Health, it was consisted of elected officials. And unfortunately, they tended to make decisions more based on the interests of commerce and businesses than the safety of the public. When a ship would arrive in port with sailors aboard who were sick, they would authorize the unloading of the cargo because of the business interests involved. So this went on for some time until 1866, when the board was depoliticized and seats were set aside for physicians and scientists who began doing things like collecting data and monitoring sanitary practices. Within a year of the board being depoliticized, they had cut cases of cholera by 90%. And so it's a good lesson that basic public health really includes sanitation as opposed to more sophisticated measures, and that's still true today. Charter reform in the year 2000 restructured the board into its current format, which is 10 experts in public health and medicine, plus the New York City Commissioner of Health. The board is appointed by the mayor with the consent of the city council. And each time I've been reappointed, I have had to go through a confirmation hearing with the city council rules committee, which has been a very interesting experience indeed. We are like judges. We cannot be dismissed without cause, serving 6-year terms. And so we often overlap from one mayor to another. They can't get rid of us so easily. And the New York City Board of Health is not an advisory board to the Department of Health. Rather, it is a statutory body. And what we do is we amend the health code of New York City. This is fairly unusual for an appointed body to actually have lawmaking authority. But that's what the New York City Board of Health has. And the New York City Health Code is hundreds of pages of regulations governing everything from, standards in daycare centers to the list of communicable diseases that have to be reported. It is an enormous breadth of issues that are covered in the city health code. And if anyone wants to change, they have to come to the Board of Health. These laws cannot be changed by action of the city council. So when it was first set up, communicable diseases were the major focus. And even when I was appointed to the board after charter reform, much of the focus was on making sure the commissioner had adequate authority. This was just after 9/11. There was concern about biological terrorist threats. And so we did a lot of work around quarantine power and really making sure the commissioner had the authority to act quickly with emergency declarations. And 20 years later, I got to see many of those provisions used in the management of COVID. And I'll talk a little bit more about that at the end. But over the last couple of decades, really much of the focus has been on the major threats to health, which are no longer communicable diseases, but rather chronic diseases like hypertension and heart disease and diabetes. And public health threats are things like smoking and obesity. And so the first series of things I'm going to tell you about really deal with the board's efforts to focus on that type of problem. But then, of course, COVID changed everything. And for the last 2 years, we have largely been dealing once again with an infectious disease threat. So one of the first initiatives that we enacted when I came on the board were calorie counts on menus. Now, you're all too young to remember when this was not the case, but this was an effort to really focus on the obesity epidemic, and the Department of Health trying to think, what could it do that would really address obesity in the city of New York? And so the way this works is the Department of Health comes to the board with a proposed revision of the city health code to either add something or remove something or revise something for our consideration. So the Department of Health came and presented evidence that the public is not good at estimating calories when they're eating out. And they actually had data from a survey of Subway customers. Subway actually put calorie counts on its menus before there was any regulatory mandate to do so. And so they provided sort of a natural experiment. And it turned out that, you know, customers said they did look at the calories when they were deciding what to buy. We know that nutrition labeling on packaged food works and helps people to make healthier choices, but when you're eating out, you don't have that information about what's going into the ingredients in front of you. And so we focused on restaurants that have standardized portions, meaning fast food chains, as they were already providing calorie info on the things they served, but it was available on the company's website if you were proactive enough to look. And so the proposal was that if we put this information on calories in front of the public at the time when they're making decisions about what food to buy, they would make informed choices and it would decrease overweight and obesity. And so the regulations that were enacted were very specific. We actually talk about the size of the font that the calories have to be in. It has to be at least as large as the names of the foods and the prices. There was a lot of guidance given to restaurants, time to prepare the signs, but the restaurant industry was not very happy with this idea, and we were sued by the restaurant industry. And actually, the first version of the calorie count rule was overturned by a court. It was, however, overturned on a technicality, and the judge practically gave us instructions on how to rewrite the rule, which we did and passed it again. It was again approved and published, and we were again sued by the restaurant industry. They lost that fight, and calorie counts became the law of New York City. And I will talk to you in a few minutes about some of the unexpected downstream consequences of having calorie counts on menus in fast food restaurants. The second initiative that the board undertook was a trans fat ban in restaurants. Now, as probably all of you as public health students know, trans fat is an artificial additive that's put in foods to extend shelf life. It is the most dangerous type of dietary fat. it does everything that's bad. It increases LDL cholesterol and decreases HDL cholesterol, has no known health benefits, and there's really no harmless level of artificial trans fat consumption. And projections done by the New York City Department of Health estimated at that time that trans fat was responsible for at least 500 deaths per year from heart disease in New York City because of the its effect on cholesterol and increasing the incidence of heart disease. So we knew, now at this point, trans fat had already been banned again in packaged foods that you would buy in the grocery store. But that labeling law is really of no use when you're eating out because you don't know what kind of oils and cooking oils and shortening were used in the foods that are prepared. So the first thing the Department of Health did was an educational campaign to restaurants. They sent out a survey to find out how many were using trans fats. They conducted an extensive educational campaign with materials offering alternatives. And then they resurveyed the restaurant industry, and there was zero change, no change as a result of the educational campaign. And so at the time that they came to us with this proposal, they had already tried the educational approach. They also very cleverly, and this really was the brainchild of Commissioner Thomas Frieden, who at that time was the New York City Commissioner of Health, went on to be director of the CDC. But they worked with several well-known restaurants to eliminate trans fat from their menus, and were able to have these restaurateurs testify that they had been able to do this and change their recipes without any complaints from their patrons about a change in the taste of their foods and no real increase in cost. And so the stage was really set for the board to approve this ban. The law was phased in over 18 months to give the restaurants time to change over their, their ingredients and to fix their recipes. And there was a lot of technical assistance from the department offered in finding substitutes and adjusting recipes. So once again, we were sued by the restaurant industry. Fortunately, there was not an injunction, so the ban went into effect while the lawsuit was being played out, and we did eventually win in court. But these two things, the calorie counts and the trans fat ban, really sparked a whole debate around this idea of the nanny state, that government was being too intrusive into our private lives by regulating what we could eat. And this book came out suggesting that somehow we were going too far. I had the pleasure of debating this gentleman on a radio show, and in fact, public health is all about restraining individual freedoms for the sake of improving the health of the public. And so where you draw the line, how much is too much, is a debate that continues. When the department revisited calorie counts 5 years after the rule had been passed, one of the interesting things we discovered is that the restaurants actually had started offering healthier choices. It turns out, for example, when Starbucks had to put labels, and you saw that there was nothing but 600 and 700 calorie muffins, that they developed some muffins that were only 300 or 350 calories once they had to put the labels on. So just putting the information in front of people actually changed the offerings that were available in these restaurants. So a very interesting consequence. And trans fat ban has now become almost endemic. New York City was the first, but there were many municipalities and states and even countries followed suit. And so trans fat is now banned in restaurants in much of the country. Now, New York City is often the first with these initiatives, but the next one I'm going to tell you about actually was not an idea that came from New York City. So this is a graph showing New York City hospital discharges for food poisoning attributable to dining out. And foodborne illness is a real problem. It's about 350,000 hospitalizations a year and 50,000 deaths across the country. And much of that occurs when people eat out rather than from foods that they prepare and consume at home. And so New York City Department of Health is actually responsible for inspecting New York City restaurants, and they inspect every restaurant every year. And what we were finding at that time was 20 to 30% required reinspection because of the number or severity of the health code violations. And restaurants were being repeatedly cited for the same uncorrected violations. And the restaurants would pay the fines rather than correct the conditions that were leading to the violations. It was just part of the cost of doing business. But that actually doesn't do much to improve the health of the public. And so giving consumers easier access to information about the sanitary conditions in restaurant was information that consumers wanted. And the idea was that if we posted these grades for restaurants, that it might create a competitive advantage for restaurants that actually had healthier conditions. So it was an economic incentive to improve sanitary practices. This actually came from LA, who had been doing it for a few years. They had some impressive data. And so we did pass the rule requiring letter grades in New York. So you have probably all seen these letter grades in restaurants. They are required to post them in a visible place near the entrance. There's an ABC system. It doesn't have to be perfect to get an A, as you can see, and you actually can go online. There is a website and you can actually read about what citations the restaurants have. Now, some of you may also have seen a sign that says grade pending. Have any of you ever seen that in a restaurant? Yeah, grade pending means that they've been inspected and they don't like the grade that they got, and they're pending reinspection while they clean up the violations. So when you see grade pending, you might be a little cautious because it means there's something in there that hopefully they're trying to clean up. But you don't know whether or not it's cleaned up yet until you see that letter grade posted.
I think this initiative works.
I think so too. And actually, everybody except the restaurants thought so, because once again, we were sued by the restaurant industry. They said it was interfering with freedom of speech to force them to post a sign. It just is interesting, the arguments that the restaurateurs made. But everybody else loved this. Zagat's did a poll and 81% of diners liked the posting of health grades. And in this poll, 35% they would only eat in an A-rated restaurant. And so that is exactly what happened when before letter grades were given, only about 30% of restaurants were getting what would have been in the A level. Once we started posting grades, 70% of restaurants got an A. And so there was this incentive for the restaurants to clean up the sanitary conditions that previously they had just left uncorrected because of the posting of letter grades. So the next initiative I'm going to talk about was not a success, but here was the idea. This was still in response to the obesity epidemic, and the board attempted to impose a portion limit on sugary drinks. Again, This is, we know that obesity has lots of adverse health consequences. There's good evidence that sugary drinks are a leading driver of obesity. Sugary drinks have no nutritional value. So these are things like sodas and, various kinds of fruit punches. All of these drinks are mostly sugar. They also presented fascinating evidence about how portions have gotten larger over time. And there's also evidence that the larger the portion, the more people actually ingest. And so whether this is psychological or learned behavior, if you have a larger cup, you are going to wind up drinking more of it than if you had smaller cups, even if a refill was available. And so the proposal, and it was clear that New Yorkers were consuming excessive quantities of these sugary drinks. So this was the proposal, that sugary drinks may not be sold in cups or containers larger than 16 ounces. Now, 16 ounces is actually 2 cups, right? So that's still a pretty generous portion. But that self-service cups also could not be larger than 16 ounces. So this seemed not to be a very stringent regulation, but as you know, there are places where there are 20-ounce cups and 32-ounce cups and really huge portions of these sugary drinks that are sold. Once again, we were sued by the restaurant industry, and this time they won. And so this control on this portion limit on sugary drinks did not go into effect. There have been some initiatives by the City Council in this regard now, because the Board of Health was unsuccessful in doing it. And I think it did raise a lot of awareness amongst both food establishments and the public about the danger of sugary drinks. And then the last kind of historic one I'm going to tell you about are salt warnings on menus. Maybe some of you have seen this little shaker next to a menu item. It means that a single serving of that item contains more than the daily limit, daily recommended limit of salt, which is, I believe, more than 2,500 milligrams a day, 2,300 milligrams. So overconsumption of sodium does raise the risk of high blood pressure, which is a serious illness. And so these are required also on menu boards in the same restaurants that are required to have calorie counts if the recommended daily limit is exceeded with a single portion of that food. We were sued, but we did win this one. The regulation is upheld, and you will notice, hopefully you'll start paying attention to them, these little salt shakers on menu boards.
I saw them at a Popeyes restaurant. That's an example.
Yes. Any fast food restaurant that's a chain is subject to these regulations. So, you know, Popeyes, McDonald's, Burger King, Kentucky Fried Chicken, anything that has standardized portions. Okay. So let's talk a little bit about COVID. So for the last couple of years, COVID has really consumed the activities of the Board of Health. As I mentioned before, the New York City Health Code gives the New York City Commissioner of Health quite extensive emergency powers when a public health emergency is declared. So there are commissioner's orders which allow the commissioner to enact regulations quickly, but they have to be reviewed and approved by the Board of Health within 30 days of when the orders are issued. So the board has been convened quite a few times during the last couple of years to review and confirm commissioner orders regarding COVID. Initially, there was guidance to the public, you'll remember in early 2020, about masking and hand washing and social distancing and travel, about rules for self-quarantine and self-isolation. There was guidance to businesses. Some businesses were closed. There were capacity restrictions. They were told what practices were allowed and what were not allowed. There was guidance to healthcare providers and institutions about testing policies and reporting requirements and practice closures, school closures, daycare closures. And so all of these activities, as the prevalence of COVID waxed and waned in the city, there have been a series of commissioner orders. New York City, which I think you all probably should know this, is actually a separate public health jurisdiction. So it reports separately, for example, to the CDC, separate from the rest of New York State. And that is because the New York City Board of Health actually preceded the creation of the New York State Department of Health. So New York City is alone amongst cities in that it's the 50 states, New York City and Puerto Rico report their own vital statistics to the CDC. So the commissioner orders sometimes preceded those of the governor and sometimes came after those of the governor. So the most recent series of commissioner orders have been, of course, around the vaccine mandates. And I'm curious as to what some of you think about this issue of mandating vaccines. What do you think? Good idea? Bad idea? They shouldn't have done it. They should have done it earlier. They did it too soon. What do you think?
I think it's a good idea to prevent infection amongst the population.
Okay, anybody else?
I think it's certainly mandatory in specific industries and occupations. Beyond that, though, I'm really glad I'm not CEO of a private company right now.
You know what? Good point. So
I think like healthcare workers, teachers, it looks like that's what you're getting at. I think no questions asked, but beyond that, I don't know. It's a tough.
Well, this is the order in which they came out, right? And so the first vaccine mandates were for healthcare workers. I think there's a strong public health argument, both because those workers are exposed and the infection of a single healthcare worker, they can then spread it to patients, thus accelerating transmission during the pandemic. And so the first vaccine mandates actually were on healthcare workers. This was a very interesting experience for me, being in the leadership of a large healthcare organization. We had worked very hard to get our employees here at Mount Sinai to vaccinate voluntarily, did lots of outreach, lots of educational programs, tried, peer-to-peer coaching. There were videos. Really a lot of effort went in to convincing the employees of Mount Sinai that getting vaccinated really was in their best interest. Now, at the time that the mandate came out, we had been about 75 or 85% successful. So there was a large portion of employees who were still unvaccinated at the time that the mandate for healthcare workers, the vaccine mandate, came out. And I have to say that when all of the educational incentives and so on had not worked, when people were faced with the idea of being terminated from their employment, and very importantly, that if they were terminated for failure to comply with the vaccine mandate, they would not be eligible for unemployment, because that was announced by the governor, that convinced all but a very small number of healthcare workers to accept the vaccine. And so we actually had thousands of employees who were vaccinated between the time the mandate was announced and the deadline for being vaccinated was set. So it was effective in getting healthcare workers to accept the vaccine.
Dr. Richardson, did you notice if there was, I mean, you've got so many employees in the Mount Sinai system. Was there a specific category of employees that were more resistant and slower on the uptake?
Yes, so we looked at this carefully. The best compliance actually was amongst physicians in terms of getting the vaccines. And I'm an emergency physician, and so we were in the first group eligible, and I think almost without exception, we were so grateful to have a vaccine available because we, were at such high risk every single time we worked clinically. But nurses were not quite as accepting of the vaccine as physicians, which surprised me because their nurses were right there with us watching people die during COVID. And then other licensed professionals like PAs and NPs were also not as quick to accept the vaccine as physicians, but still better as a group. The real problem came with our support staff, many of whom are frontline workers, transporters and nurses, aides, and so on. That is a largely Black and Latinx population. And so they certainly had some significant concerns about the vaccine. And again, I think we worked very hard using lots of different strategies to give them the information they needed to make a decision. But it was uneven across both employee job description groups and across racial and ethnic lines in terms of compliance, mirroring to some extent what's happening in the larger community. Teachers were next for the mandate, so the Department of Education issued their mandate, and most recently, the mayor has released a mandate for all city workers and contractors who work in city buildings and agencies. So what do you all think? Healthcare workers and teachers, okay, but all city workers and contractors. And I have to tell you, the nature of the discussion went from, again, healthcare workers with there being very specific public health considerations to the need to get as much of the population vaccinated as possible. And the Delta variant really made all the difference. I think before that, there was a feeling that, well, if you don't get vaccinated and you don't protect yourself, that's on you. But what the Delta variant showed us is that the people in the proportion of the population that is unvaccinated has become a breeding ground for new strains and variants of the virus that are more infectious and possibly more deadly. Delta is not more deadly, but it is more infectious. And so people choosing not to be vaccinated puts not only them at risk, it puts those of us who were vaccinated as risk. And that is when the conversation about vaccine mandates went from being something that nobody really wanted to think about, that everybody thought we had to do. And given that line of reasoning, if in fact you being unvaccinated presents a danger to the health of the public, then mandating that you be vaccinated is a legitimate action for a public health authority to take. So this is really where we are now in terms of the thinking on vaccination. And as somebody mentioned, it's hard if you're a CEO of a private company. What do you do? Many corporations have issued mandates for their workers, and all of those have been held up in court, by the way, because there's always someone who sues. when that is mandated. And I think we may yet see a mandate on private employers from the government requiring them to require the vaccine. We're not there yet, but that would be the next logical step in this progression. But let me ask you another question. What do you think about religious exemptions to the vaccine?
I think it's really hard to prove. You know, there are some religions where you absolutely want to take into account some of those religious exemptions because they are valid. But for those who might be using religious exemptions as a scapegoat, it's just really challenging to prove, and it still puts that population at risk, right?
Absolutely right. So what might constitute a valid religious exemption?
I was just gonna say, I'm not aware of any. So, I mean, but I'm not an expert in religion. So,
Yeah, I was gonna say the same thing. I mean, I always hear people saying like religious exemptions, but like what, like I mean, if anybody knows or you know, Dr.
I know, like I totally respect it, but like what religion? I don't know.
Yeah.
Well, I think like what I've heard is, and I've not done my research, so take this with a grain of salt, right? But what I've heard is that there's been some speculation that the vaccines have been created through, is it embryos or fetuses? And so, you know, certain religions are.
The stem cell thing.
There you go. Yeah.
So I also have heard that assertion. That is untrue. The mRNA vaccines do not include any type of fetal material or stem cell material at any point in their development. So you might have a religious objection to taking the J&J vaccine, but that would not apply to the Moderna or the Pfizer vaccine. And so I'm with you. I mean, I am not aware of any religion that has a specific prohibition against being vaccinated for a disease, right? Because at the time most religions formed, there were no vaccines. So this is different than rules about accepting blood products, for example, right? Because there was use of blood products historically, or objections about the use of fetal material or embryos and so on. So the new technologies have rendered the grounds for religious objections to other kinds of treatments moot at this point. They don't apply to the mRNA vaccines. And so it is hard to understand what would constitute a valid religious objection. Now, does it have to be an organized religion? Can I like institute a new religion and make a rule against vaccination? Is that a valid thing? These are the kind of questions that groups that have to review and decide about these religious exemptions are going through. One of the speakers made a good point that even if there are some valid religious exemptions, how do you know that an individual truly has a religious exemption versus they just don't want to do it and they're claiming a religious exemption? And that certainly is an issue with other kinds of public health recommendations and mandates. But for this one, I have not yet heard a case for a valid religious exemption to the COVID vaccine. Now, there are a couple of medical exemptions, but they're all temporary, right? So that if you have had COVID, for example, it's recommended you not get the vaccine. It was 30 days, then it went to 90 days. Now I think it's back down to 30 days. Similarly, if you were treated with monoclonal antibodies, there's a recommendation you not get the vaccine for a specific amount of time. So there are some valid medical exemptions, that are being honored in these mandates until you are out of the period where you're no longer ineligible to get the vaccine. But these are in court now. Initially, the state of New York said they would not grant any religious exemptions, and everyone proceeded along that line. It was taken to court and an injunction was issued so that the religious exemptions, at this point, people are not being terminated if they filed a religious exemption pending review and consideration of their religious exemption. I'm not aware of anybody who's actually gotten a religious exemption. I think there are some places that are very reluctant to rule. They're maybe waiting to see how the court case comes out. And the medical exemptions are being tracked over time. But this has become a big issue. It's a lot for the employers to manage. But I think that the issue will only get bigger as the categories of people for whom vaccine mandates are enacted becomes larger. So in the last few minutes, I do want to talk about a very recent action of the New York City Board of Health, and that was the declaration of racism as a public health crisis. Now, this actually was first a statement made in 2020 by Osiris Barbeau when she was then New York City Commissioner of Health, declaring that racism is a public health crisis, and that really we are in the midst of two pandemics, COVID and racism. But much more recently, the Board of Health enacted a resolution. Again, this was drafted by staff in the New York City Department of Health. And it's quite extensive and far-reaching. There are 2.5 pages of whereases. If you've ever seen the format of a resolution, whereas this and that, whereas racism is bad, and our history is full of racism, it goes on and on for 2.5 pages. But then there are the be it resolved, and there are actually 9 action items that are part of this resolution. It includes assuring a racially just recovery from COVID-19, very interesting language. Another interesting provision is that the historic role of the New York City Department of Health should be researched and identified and acknowledged to see if there was underinvesting or divesting in critical community-led health programs that harmed communities, and that the department should undergo a truth and reconciliation process with the communities harmed. Some of you may be familiar with this idea of truth and reconciliation. Probably most famous example is in South Africa after apartheid. There was a national effort to really talk about the harms that had been done by some factors within the population to others so that they could move forward. So this has been suggested as something the Department of Health should do. They established a data for equity work group that's looking at, quote, intersectional anti-racism equity lens, looking at public health data of all kinds. There's a recommendation that all reports on fatalities, injuries, and health conditions should be done by race, gender, and other demographics so that we can track health disparities. It's been recommended that they perform an anti-racism review of the entire New York City Health Code to see if there are any elements of structural racism embedded within the code that would need to be dismantled. To also consider whether there are anti-racism health-related charter revisions that should be made to the New York City Charter. So this is the larger body of New York City law, not just the health code. And then this really far-reaching one, which invokes not just the Department of Health, but other relevant organizations and agencies to really look at whether or not there are elements of structural racism within the policy plans or budgets related to transportation, education, housing, economic opportunities, land use, civic participation, or healthcare delivery, and make recommendations how to mitigate harm within a public health context. So this is, I think, an extraordinarily far-reaching set of actions that are planned by the Department of Health and Mental Hygiene. This resolution was brought to the board actually a couple of meetings ago in October and was unanimously passed by the New York City Board of Health. So what do you all think about this? Racism is a public health crisis.
I think it is a good idea. And these ideas are like giving reparations to the community and repenting, a kind of reckoning and repenting.
So you approve, okay. Anybody else?
It doesn't feel quite specific enough to me, but maybe, I mean, I'm also not familiar with what other, like, you know, if this is the kind of common type of language, but it feels like, what does this actually mean? I don't know. And how is it held up? Like, how do you know if someone's not doing this?
Well, these are very good points. So I did obviously paraphrase some to fit it on the
Right,
slide.
sure, yeah.
I believe the full text of the resolution is available online for you to read through it. And again, the each one of these really lays out sort of a plan or a set of actions that then would actually have to be operationalized and carried out. Now, it did include, the resolution did include a requirement to report twice a year to the New York City Board of Health on the progress of each one of these activities. So
Like
there's at least some transparency proposed that they would come clean, because Board of Health meetings are public. By law, they're public, anybody can attend. Even on Zoom, you can Zoom in. And when we go back to being in person, you can come and sit in the room and listen, and they're all recorded and available online. So they have basically pledged to go public twice a year, reporting on the progress on each one of these points, what has actually been done.
Got it.
But it was a, it was a voluntary commitment to do this. So the holding accountable part is really, they can only hold themselves accountable, but they did promise to make public their progress every 6 months.
Sorry, and this might be stupid, but when you say they, are you referring to
The Department of Health, the New York City Department of Health and Mental Hygiene.
Got it.
So
Okay.
these are actions that they are going to take, and then they're going to come and report to the board on what they did.
Yeah.
I
Yeah.
thought the timing of this is interesting. What do you think? City agency, we're about to get a new mayor. Will this survive the mayoral transition? What do you think?
It depends, but I think it's a good start. It's perfect timing.
Okay.
I hate to be a cynic, but I think it's highly convenient. I feel like perhaps, these sometimes things like this are presented during an election season, and after the election passes in whichever direction, whoever wants it to kind of flow through, then, falls off people's desks, and, we readdress again in another 2 to 4 years.
It will be interesting to see what happens. I don't know that I would call that cynical, skeptical for sure. I think that's okay. And yes, I thought the timing was interesting. We actually asked that question of the staff that, well, why now? It seems odd that you would come forward with something that has so many implications, because this will require staff time and money to actually do these things. But there clearly was a core of very committed people within the department that put this together and did this work. And they were able to bring it forward, perhaps wanting to get it on the record now so that there would be a better chance of not allowing maybe for the possibility that it would be squelched under a new administration. Who knows? But I did find it to be very interesting timing. And so, you know, that really brings me to the end of the talk. You know, public health policy, you know, is always done in the context of the real world. And there are always competing agendas. I'm obviously very much in favor in following the evidence for health-related decisions, but health-related decisions can have financial consequences and legal consequences and political consequences. And when, as a board, we are considering these initiatives, we do try to take all of these things into account. When there's a regulation proposed, we do ask, well, what will the impact be on the businesses that have to conform to this? How much will it cost them? What are we going to do to mitigate that cost? Because there's always implications of any action we take. So as you move forward into your future professional careers, just understand that this is complicated stuff, doing public health policy. And obviously it should be evidence-based. I think that policy should always be evidence-based. You have to use best available evidence, even if it's not ideal, but you also have to consider all of the consequences of your actions and not just the health consequences. And you have to weigh the benefits and the costs with every decision that you make. So that's what I have. Are there any final questions?
I just had one quick question. You had mentioned downstream consequences of the calorie counts on menus.
Mhm.
What were those? Or like, were there any negative ones that came up? I was just curious.
No, what I was referring to was the changes in the offerings by the various food establishments.
Mhm.
They actually developed healthier options
As a response to that.
as a response. So
Got it.
when nobody knew how much it was, and it was, I have to tell you, it was kind of staggering when it was first enacted. And it's not that I don't like Starbucks, but that was particularly egregious that literally there was not a single thing sort of in their pastry menu that was less than 600 calories.
I remember that. It was like when I was first thinking about moving to New York City, and I would like come and visit and be like, whoa, what is this? And then you're like, oh my God, it was like this whole new world of it.
It was, I mean, one muffin is 600 calories.
Yeah.
It was sort of, and some of the drinks. So
Yeah.
they had to make some things that were only 200 calories, 250 calories. And I don't think that would have happened if they had not had to display the calorie counts.
Do you know, or is this kind of out of your scope, but would you ever do like a follow-up to see, has that affected obesity rates in New York City?
Well, it's very hard to ascribe any changes to a single policy or initiative. There have been studies to follow up to look at sort of the average calories ingested at establishments where there are calorie counts. And initially, there was a slow decline. It bottomed out, and now it's actually started to creep up again. But again,
there's so many variables.
There are so many variables, and maybe people now have gotten used to it. Maybe people don't even notice the calories anymore. I mean, how many of you, do you always check when you're at a place that has the calories? I mean, I do. I go into Subway and I say, wow, meatball parm is like 100 calories more than the, sweet chicken teriyaki. I guess I'll get that one. I do make those comparisons in real time when the calories are in front of me. So.
And just one other quick question, sorry. Why did the sugary drink, why did that not pass? Like, why did that, yeah.
Well, so just so you understand, I mean, the way these court cases work, the restaurateurs had like 12 different legal theories on why it was unconstitutional to have such a ban.
Yeah.
And ultimately, the judge decided that the Board of Health did not have the authority to regulate commerce in this way.
Okay.
We actually think they were wrong. We think it was bad law. It was a bad decision by a judge, but
it was that judge.
The way the judicial system works.
Right.
But the role that New York City plays in really being in the forefront of these kind of initiatives is important because you do get sued. Now, the New York City Department of Health has its own legal counsel. That legal counsel also defends the Board of Health when we get sued. We don't have to hire our own lawyers.
Mhm.
But if you're in a smaller town or city and don't have the resources to fight a legal battle with the restaurant industry, which, believe me, is powerful and well financed,
Yeah.
you're not able to make these kinds of provisions and policies.
Right.
But a city like New York can do it, let it go to court, let us win. Now the precedent has been established, and then other smaller communities can follow suit. And so we saw that with the calorie counts, we saw it with trans fat, we've seen it with many of the initiatives that we've started in New York City. And so the legal implications are something you have to take into account when you're making policy. Where are you? Are you likely to get sued? Are you in a position to defend that suit? Or is that going to sap so many of your resources that you really can't afford to take that step? And so I really enjoyed being a member of the New York City Board of Health and watching this really activist public health department take these kinds of actions, put themselves out in front, take the hit, draw the lawsuit, go to court, and we've won many more battles than we've lost in court, and then watch it sort of disseminate across the country. And so it is important that a place like New York uses its resources to move these kinds of initiatives forward, because not every place can, not every city and town can.
Okay. Thank you.
Okay, I think our time is up. This has been fun. It was my pleasure, and good luck to all of you as you
Thank
pursue
you.
your public health study. Okay,
Thank you.
bye-bye.
Thanks so much. That's
Thank
you.
you.